Ian was saying, I've written stuff for quite a few years, largely blogging, and started really with that, and then moved into doing more articles. And finally, my could say my dream came true of writing a book. It wasn't always what I thought I would have written, but I was I think, very lucky to get it published. It's very difficult to get into these things, and it's been very exciting. It's been quite stressful, and it has meant that I'm talking about things that I've always been quite open about, but are still quite difficult to say. And sometimes I wonder why that is. And I think, it does imply there are still difficulties in our services, in our way of living. But thought for this evening, I thought about what to talk about. As I say, the book took a long time to happen, and I'm delighted to see it published. Um, but it's a book, and when you write a short piece, you can focus it. You can decide what to include. You can write it about stigma or whatever, and write about yourself. Just include what you want to include. But if you write a whole book about yourself, it's very different. There's not anywhere to hide really, and I'm sure I've missed bits out, either bits that I just can't write or bits that I can't remember. But there's an awful lot that is included. And even just before coming on this, actually, I was looking at something I think my cousin had put on Facebook that he was going to read it, and I just felt complete panic. It was just, but I think that's what happens when you do something like this. So I thought about a few things before I come to what I'm mainly going to talk about. Is the stigma, obviously, of mental illness, and it's kind of what I started writing about in the start, and it remains important. My current psychiatrist tells me that I self-stigmatize, and he may be right, but you do need some kind of information to do this. It has to come from somewhere, as it would be hard to do it otherwise. You need to have seen it happen. So I don't think it's all self, although I do agree that maybe I'm oversensitive. And I also thought about the doctor-patient relationship from my perspective, largely as a patient, but perhaps one who knows what it's like being on the other side, as I think that's something we can often ignore, and at least partly because we don't always get to follow up patients for long these days. And if possible, we're encouraged to discharge people. I've been incredibly lucky that I've seen the same doctors, psychiatrists, and got to know them better and them me. And I think that may be what I talk more about in the winter meeting, actually. And again, treatment, nasty drugs and ECT. I mean, I've talked quite a lot about them in the past, and I thought, well, yes, I've got a lot to say about that, but I'll not say it tonight. And in the end, I thought that perhaps tonight would be a good thing to talk about diagnoses, really, very much from my perspective as a patient. I knew very little psychiatry when I was first unwell. I mean, I'd been through medical school. I just don't think I picked up that much, really. And but then hopefully later with kind of added insights after I became a psychiatrist. But when I'm a patient, I'm still a patient. And as I said to Ian at the beginning, this isn't an academic talk. It's taken from my book and is about what happened to me, really. So a few kind of general things about diagnoses that when I started out, and this is just something I was thinking about, not from my book, psychiatric diagnoses were not something you wanted to have. And I'm not saying they are now, I don't think they are, but things have changed a lot. And from my experience as a psychiatrist, even working in addictions and chronic pain, and where we see a lot of people with a lot of mental illness, my experience on social media, where I do go, and even just talking to people, people are more likely to have a kind of handful of diagnoses now of various different types. And I do find this concerning because it kind of suggests that maybe our diagnoses aren't that good, or maybe there's something else. Maybe we're diagnosing something about people that isn't actually a mental illness. If they are right, then what is going on and why? And why is everything being pathologized? And I'd be really interested to know people's opinions on that, because I'm sure we're all aware of that. So, enough preamble, back to my experiences. And what I'm going to do is read a few extracts from the book relating to these kind of issues. And the very first one describes some of my thoughts when I was first a patient in the Royal Edinburgh Hospital. I think at that time I was expecting my first daughter, and I was just, I didn't know what was going on really. So I also concluded very early on that I had a personality disorder and that everyone else thought this too. I heard a couple of the nurses talking about one of the other patients. There's a lot of behavioral stuff going on there. I think we need to set a few boundaries. The other agreed. Yes, I heard her with Jill, and I mean, Jill's really unwell. It's not fair. Well, I'll have a word with Dr. B later. It's busy enough here. We don't want any acting out. I was vaguely aware, even as a patient on the ward, that some people were expected to take responsibility for their behavior, but not others. And these were the patients with personality disorders, and I was one of them. No one said this to me, but I was convinced. Personality is a strange diagnosis and one that can be used rather slackly in psychiatry. Borderline or emotionally unstable personality disorder is a label given to many female patients, although males are by no means exempt. And it comprises a combination of symptoms, including emotional instability, fear of abandonment, difficulty with relationships, transient psychotic features, never been quite sure what that is, and self-harming behavior. All of these symptoms can also occur in other disorders, which is confusing. Many people who are given this diagnosis have experienced trauma or abuse, often sexual abuse, and some have had unimaginably difficult lives. They've often learned ways of living and of managing their feelings that can lead to some of the symptoms described. I think attitudes have changed somewhat over the years, but there is no doubt, even now, that it can be a punitive diagnosis. After all, who wants to be told their personality is disordered? Other illnesses, like schizophrenia, bipolar disorder, and severe depression, are often seen as having a more biological or medical cause, and as such, are thought to respond better to drug treatment. But nothing is that black and white. My understanding of psychiatry at that stage and in my state of mind was rudimentary, to say the least. To me, personality disorder meant person with no genuine mental illness, behaving badly and disliked by all around them, particularly by health professionals. To be fair to myself, I had observed something of these attitudes, both as a student and at times as a doctor, so the leap to applying this to myself was a short one. It waxed and waned a little, but always returned. It affected my own view of myself, but also my ability to interact with staff. Even when they were kind, I assumed another agenda. So that's the end of the first extract. I don't think I'll say anything particular about that, but the next one is time-wise is quite a bit later. It was taken from when I was a junior doctor in the Royal Edinburgh Hospital, same hospital, and it's probably about 5 or 6 years later, give or take. I spoke to my consultant supervisor about my illness during this post, and he was very supportive both then and later. I remember him saying that he thought it was very clearly biological, in other words, a proper mood disorder, rather than a reactive or even a behavioral problem. In some ways, this was absolution from my worries that I had a personality disorder, and was perhaps his way of saying that none of this was my fault. I was cautiously pleased, as maybe it meant that I was a reasonable person after all, but also rather troubled. It was only his opinion, after all. But it also confirmed my fear that if I didn't have a proper biological mental illness, if any of this had been due to my life or behavior or personality, then he would not think so well of me. I was also starting to think more and more about those poor people without so-called biological disorders. Did this make them bad people, attention-seeking and unworthy of kindness and help? They often got short shrift in hospital unless their behavior was so extreme that they simply could not be discharged. It seemed very clear to me that there were diagnoses that were more acceptable than others. Even now, when I'm comfortable to disclose my diagnoses of depression and bipolar disorder, would I be happy to say that I had a personality disorder? I don't think so, yet it is a very distressing and debilitating condition. That's the end of the second extract. I'll warn you now, the third one's a bit longer. I was reflecting earlier today, actually, reading that second one. And one of the things that struck me when I was kind of reading it out loud was the word absolution, which I'd obviously written at the time, and its association with guilt and forgiveness. And in some ways, I think that's quite opposite. I do remember during those early years that I did feel that somehow I needed to be forgiven or be allowed to, lead my life as I would have done before. And that may have been partly just my interpretation or my family's way of looking at things or something, but I don't think I'm entirely alone. And I think it can also represent the power imbalance that we can often be aware of. And again, I'd be interested to know what other people would think of that. So the last bit, which is a bit longer, is actually in the final chapter, and is more of a reflection about my feelings about diagnoses. So I'll go through that, and then a little bit more about the whole thing. What is my diagnosis? Does it matter? I think it does, and I also think it can be very hard to decide, sometimes impossible. As psychiatrists, we make diagnoses using groups of symptoms, groups of signs, but we see them subjectively, however much we might like to think that we are objective. What you think is anxiety, I might think is elation. This might not always matter, but sometimes it does, both for one's own understanding and belief in oneself, and also for treatment. Sometimes it may be very obvious what is wrong. My own specialty of addiction psychiatry is easier in some ways, with breathalyzers and drug screens to confirm our suspicions. But even then, there are other more elusive diagnoses that tag behind the obvious ones, and they can be very hard to get right. They're often even harder to treat. Looking back, I think that it is clear, even to me, that I had a psychotic illness before and after having my first baby. My mood was predominantly low, but with intermittent periods of marked pressure and agitation. I thought at the time that this was not a perinatal illness because it started before I had my baby, but I was wrong about such time restrictions. I've since had many episodes of low mood, some of irritable and agitated mood, and a few of high mood, some but not all when on antidepressants. I know, looking at that list of unfortunate events, that a diagnosis of bipolar disorder cannot really be denied, but I still want to. I don't want any diagnosis. And I really don't like the idea of this being something that is beyond my control. I think that is one of the main problems, that this disorder is what you feel and what you are. And because of this, I've always felt that I should be able to control it. My treating doctors, the two main ones being Prof. Blackwood and Prof. Laurie, have always been crystal clear in their message to me that I have a mood disorder. They've moved a bit between depression and bipolar disorder, but they have strongly resisted all my arguments for other diagnoses, usually personality disorder. Changing diagnoses can be a problem for many patients. You're just starting to believe in a diagnosis when someone else suggests something different. It is, of course, incredibly important to keep diagnoses under review, but it's also vital to think what that is like for the patient to experience and how it may affect their treatment. Bipolar doesn't exist in a vacuum, though. It is part of any person with all their differing complexities, and there are a number of disorders that often coexist. One of these is anxiety disorder, which comes in a number of guises and which for me has been lifelong. There were high expectations placed on me as a child, and perhaps I reacted to this by raising my own expectations of myself beyond a reasonable level, something that may have contributed. On the other hand, there are plenty of anxious people in my family, and who can say whether my anxiety was caused by biology, psychology, learning, or a heady combination? But I was always anxious, particularly socially, and I also have a degree of obsessive compulsive disorder, another common friend to mood disorders. I have a lot of rituals that I perform. They fall off when I am well, although they never actually disappear, and then they re-emerge when I become ill. Most of the time, they cause me little in the way of problems, but sometimes they make it harder for me to do things. People with bipolar disorder also have an increased rate of substance use disorders, as do people with both anxiety and obsessive compulsive disorder. So the odds are somewhat stacked against me here, and perhaps I'm lucky that I don't have a substance use problem, but it is my opinion that I will always have to keep an eye on my alcohol intake to stop it creeping up. The main thing with all these different diagnoses is acknowledging that they can all exist together and not trying to attribute all past symptoms to the most recent diagnosis. If, for example, I did develop an alcohol problem in the next 5 years, it is very possible that a doctor who did not know me might assume that my previous mood symptoms had all been a result of alcohol use. This is not an unreasonable question to ask, but it is a very unreasonable assumption to make. And once recorded in my notes, it might become irrefutable, particularly if I did not know it was there. There are many very messy aspects to psychiatry, and nothing quite fits into neat slots, however much we want it to. The personality disorder slot is one I've thought about much over the years. Many of my most damaged patients fit that diagnosis, but the important thing is that it should be a diagnosis of sympathy and understanding, and not one of exclusion and criticism. The difficulty is that we often lack the resources and skills to provide the therapy that might help these patients. And like so many of my colleagues, I truly regret that. So, although I have often said that I have a personality disorder, I feel ashamed of this now, and that I'm actually perpetuating the dismissive and critical attitudes that can attach themselves to it, even if only to myself. It is a sad reflection that I am choosing the most self-critical diagnosis I can find to castigate myself with, even if it is not something I would do to my own patients. In fact, the stigma of mental illness and the different values attached to different diagnoses are a problem. Self-stigmatization is common in doctors and other health professionals and may reflect their own hidden views or the way they have heard others talk. Stigmatizing views are hopefully held by a minority in the profession, but they are always the ones that patients more often hear and ruminate over afterwards. We don't hear the positive things always that people say about us, particularly at times of great vulnerability. The other problem with the bipolar diagnosis is its universality and its connection to various well-known figures. Many of these have been great ambassadors for mental illness, but I think that there can be confusion in the general public, some of whom see any form of mood swing, however brief, as a type of bipolar disorder. Even amongst psychiatrists, there are those who are well known for making this diagnosis in situations where others would either be cautious or would withhold it. But it can be very upsetting and invalidating for a patient if the diagnosis is subsequently unmade or discredited. That's the end of the bit from my last chapter, but I was thinking after that a little bit about the changing diagnosis thing and what happens with that. And I've actually got another bit that I will read if that's okay. It's adapted from my a thing about my blog. It's a blog called Changing Diagnoses. I kind of adapted it a bit to do it here. I'll just say now that my blog has nearly 90 posts in it regarding all my various thoughts about everything. So if anyone wants to ever look at it, they're more than welcome. Moving to that, and that will be the last thing I'll read. So much of psychiatry is opinion. The discussion about a potential mental disorder may be stimulating and interesting for the clinician, perhaps rather less so for the patient. I'm concerned about the dichotomies in different clinicians' opinions about illness and treatment and how they reach these. At times, it may even be based on an episode of seeing someone diagnosed or treated for something, resulting in a eureka moment and subsequent generalization. So to illustrate that, a few people have told me that they only began to believe in ECT as a treatment after seeing me get better. These were clinicians. Well, I'm delighted to get better, and it may well be ECT, but of course it may not be. Apparent response to any treatment does not necessarily prove a diagnosis, perhaps especially in psychiatry. And interestingly, I've heard a lot of people, patients and relatives alike, say recently that responding in some way to ADHD treatment proves the diagnosis. I'm not sure about that. My own diagnosis of bipolar disorder may or may not be correct, depending on what correct means. I'll never have complete belief, but it matches up to diagnostic criteria. And my husband, who's not a psychiatrist or indeed a clinician of any kind, seems more certain of it than I do. But maybe it's easy for him, not being trained in the art of psychiatry. He also observes and remembers where I experience and forget. What I do feel strongly about is the game of changing diagnoses. And I use the word game as it does sometimes seem like that. My own experience of a changing label from depression to bipolar disorder, back to depression, and then back to bipolar does seem fairly representative. And it actually hasn't been too bad for me, perhaps because I had longer term psychiatrists. However, I know from speaking to people and increasingly reading people's experiences online that many struggle with diagnoses being given, diagnoses being changed, and even just removed. I think this might be more manageable if more of us had the same clinician caring for us over the years. And I've been lucky in this. As someone changing a diagnosis that they've made themselves is far more understandable, and hopefully they would give a good reason and explain. However, if you see a new psychiatrist and they say, well, I know so and so said you have such and such a diagnosis, but I don't agree. I think you have something quite different. That can be very difficult indeed. And my personal experience is that it can take a long time to accept a diagnosis. And when someone changes it, I think, well, they clearly don't agree with each other. So quite likely they're both wrong. Now, I know that getting a diagnosis right can be very difficult, and it's very important to get the right treatment and to minimize iatrogenic harm. But I also know that diagnosis can sometimes be changed on the basis of one appointment. And if the change is to, for example, personality disorder, that can be devastating. I'm also aware that some clinicians have a reputation for making particular diagnoses more than others. It's quite talked about. As a psychiatrist myself, I can think of some who are reputed to diagnose bipolar disorder in very many of their patients. And this is a problem overall because some of these patients may not have bipolar disorder and may be treated with medications like antipsychotics, which can cause harm, which is unacceptable if unnecessary. And they may also have other problems which are not being treated. However, given the population prevalence, some of these patients will indeed have bipolar disorder. And that's also a problem, as there can be an assumption by others that they don't. I like to think another clinician will quickly realize that they did, but the credibility of any diagnosis should not depend on the individual psychiatrist. Ultimately, it's all about communication, and no one should have a diagnosis given or changed without a clear explanation. And if the patient disagrees, this must be heard with an open mind and a genuine open mind. We like to have open minds, but it can be difficult. The patient sees more of themselves than you do. If a second psychiatrist later disagrees with the first, maybe they need to speak to each other, as regrettably, the changing diagnosis game can sometimes have a feeling of point scoring. There's also a lot said about diagnoses of mental disorder being less convincing than their physical counterparts. Well, that may be true because we have less diagnostic tests, really. But psychiatric disorders have patterns of symptoms that represent throughout the generations and centuries. And melancholia, for example, and mania is fairly consistent and definitely not new. Drunkenness, going back to addictions. And classifications will change. Hopefully, treatments will improve, and we need to be open to this. And shades of grey are often better than black and white. And if anyone is sure of something, see this on Twitter quite a lot, be a bit worried. And really, finally, to my mind, the most dangerous thing in psychiatry is often certainty. That's me.
Thank you so much, Rebecca. That wonderfully clear, just like your writing. You speak very well, and we'll throw open. I mean, I'm very aware, that we've got a big conference coming up in March about Emil Kraepelin. 100 years since his death. We're a year early. I think he died in 1926. I've read some of his stuff in translation. And I think we're still in a Kraepelinian world. So bipolar equal manic depressive insanity and schizophrenia, which he teased apart these two phenomena, syndromes.
Yeah.
So for him, the crucial thing he said was prognosis. So, so he I think had the longitudinal view when he came to that system. And it's kind of, maybe you don't know until a few years down the line
Yes.
what the diagnosis is. And I'm fascinated by that. I mean, I
Yes.
think and others know, my mother had schizophrenia
Yeah.
after she had my brother.
Mhm.
I was 3 years old. And when I read Kraepelin in translation, I thought, wow, his powers of observation.
Yeah.
My mother did this thing where when she was writing, she'd put a full stop after every letter of every word. And Kraepelin had a patient described that just did exactly that. And I thought, wow,
Yeah.
this man was observing so closely. And
Mm-hmm.
I wonder why we're still in a Kraepelinian world when it
Mm-hmm.
comes to bipolar, schizophrenia, what? Because I think in the 19th century, diagnostic systems were an absolute mess.
Mm.
Somehow this emerged.
Mm.
I don't think psychiatry for severe and enduring mental illness has escaped that.
No.
But I think the other thing that strikes me, and others will jump in on this, is 40 years exactly in psychiatry now, and as you were saying, the whole personality disorder thing is the main thing that's changed.
Yeah.
And you're speaking at the winter meeting of the
Yeah.
College of Psychiatrists in Scotland. A few years back, I was there, and I was amazed. There was 3 or 4 women, maybe, and one guy, and they were all in front of us to tell us they had borderline personality
Mm.
disorder.
Mm.
That having that diagnosis, I think Andy Williams, maybe the
Mm.
psychotherapist, had organized this
Mm.
and
Mm.
transformed things for them. And it felt a bit awkward to me. I don't know
Yeah.
why. And that's maybe my early psychiatric career
Yeah.
prejudices coming in or something. But for them to have that diagnosis, they felt was helpful. But
Yeah.
I don't know if you were at that meeting. But
No, maybe I can't remember. I've certainly spoken to people who have felt, and I've had patients come in who felt that that diagnosis explained a lot and was helpful. I
yeah,
think it maybe depends partly how it's done, and maybe the thing you say about prognosis is quite important. Where is this illness going,
yeah,
and that also ties in with having a one-stop shop at the psychiatrist isn't really much good seeing someone once because things might be completely different, a year down the line.
yeah.
But I suppose it does feel a lot of the treatments aren't very different than they were
No,
30 years ago. But I think as well, I'd be interested to know what you and others think about I mean, we are definitely seeing patients who come in with a handful of diagnoses,
yeah,
not just one. And I don't really know what to do with that.
yeah. And of
It's,
course, the other big change in our, well,
yeah,
10 years younger than me or whatever, but is the internet and
yeah, yeah,
accessibility of information and people
yes,
to each other through social media. So yeah,
yes. But
um, yeah. I
yeah.
think handful of diagnoses feels right for this point in time. Can we throw open? Can some others maybe come in and David Finlay? Yeah, you're
I
muted.
can't,
Yeah.
I
Sorry,
can't,
and
I can't see
just
anyone
unmuting.
else. I can't see anyone else, just you, Ian. Can't hear you either.
I've certainly got a screen with just about everybody on it. Yeah.
Yeah, I've not got the screen with everyone on it. Oh well.
It was really not to say anything profound, which coming from me will surprise nobody. But to thank you very much for the presentation and to suggest as a preamble to the rest of the discussion that psychiatry would be very much better off if neither the diagnosis of personality disorder nor DSM-5 existed.
I found, I mean, I think again, I'm answering from my own perspective, but I found not not what personality disorder is, but what it means. And I think a lot of that's to kind of help, health professionals often as tormented me over the years. It's been a problem, and it becomes more of a problem when I'm unwell, actually, as well. I don't know if I can alter this to change to anything. Oh, wait a minute, gallery view. Let's see what we can do.
Yeah.
Yeah, there we go. Oh, that's much better.
Oh,
yes.
Good. You fixed it. Good.
yes, that's nice to see people. Yeah. But I don't know what would. I mean, it just feels like I've actually felt recently there have been slightly less people with the personality disorder diagnosis because there's so many other diagnoses, or it's just one of many. I mean, it's. I think I've noticed it particularly in my chronic pain clinic, but yeah, don't know whether other people think about that.
I think it's interesting in substance use. I think, there was Nick Seavright did research on this years ago, that if you took operational criteria to our patient group, you know, 60, 70% would meet criteria for some kind of personality disorder.
Yeah.
But mainly in substance use, addiction, psychiatry, we ignore the person. Maybe because many of our and to what extent their antisocial behavior is produced by their drug addiction and so on. Or, is it circular because illicit drugs equals being antisocial and so on. It's tricky. Yeah, I don't. Well, personally, I don't really like to diagnose personality disorder, but
there's something about the personality that it depends how you kind of think about it. But it was like like I was talking about absolution and things like that. I think it's almost it's kind of I'm not a religious person, but I think it's sort of about what you are, and saying that that's disordered is quite tricky.
Yeah, I agree. David Crossledge. David.
Yes, thanks. And thank you very much, Rebecca, for sharing so much of yourself and getting this discussion going. I think I'm just sort of picking up actually on two aspects of what you've said. One of which is that I think there is a dilemma for psychiatry about how we make sense of the fact that mental ill health is such an intimately personal matter, in a way which our colleagues in other branches of medicine, it's not quite the same. So we have to sort of have some way of bringing the idea of the person in, and whether that then sort of clumsily comes across as some form of personality disorder talk, I don't know. But the other bit, which might be linked to this actually, is the idea that there's a moral phenomenology to mental ill health, which you can't get rid of, I don't think, in spite of our best efforts, because we end up, when we are unwell, not being the person who is good to be. And we, at some level, know that. And the not being good, who it is not good to be, is well, you use the phrase self-stigmatizing. There is we're getting into the arena of shame and self-conscious emotions and the sort of social dimension of our identity. So I think there's something peculiarly personal about mental ill health. It's not a freestanding condition like a broken leg is, or something like that. It's something which is has a moral phenomenology about it, which we neglect in our attempts to talk about it, because that sort of sounds as though it's doesn't belong in medicine. But I think it's a sort of ineradicable part of the whole picture. And I was just interested because I thought you touched on that.
Yeah, I think that's very interesting. And I found myself thinking when you were speaking, it's easier to show bits of your body to a doctor than your inner feelings. Or, I can think of times when I felt so ashamed about, and you don't want people to know that even then. But I think the moral phenomenology thing as well. I think I felt recently that it's quite difficult even to acknowledge that in current thinking. It's almost, I do worry that we end up being a slightly separate thing, but more stigmatizing because we can't talk about stuff because we don't want to be seen in any way of, I just find it a bit difficult at the moment with that. But what you're saying is very interesting.
So I'd like to put my hand up, but I can't work out how to do it, so I'll just butt in. I hope that's okay.
Please do, John. Yeah.
I mean, I agree with what people say about personality disorder. I'm quite heartened by complex post-traumatic stress disorder appearing in ICD-11 because I think most of the people we diagnose with emotionally unstable personality disorder actually are better placed in something like that. I think it's an improvement for two reasons. One, it's less stigmatizing, but also because I don't think psychiatrists or many people understand what we're doing when we're making diagnoses. And there's there's a big literature on this, which most of us aren't that familiar with. But broadly speaking, diagnoses can be either explanatory or they can be descriptive. Now, most of our diagnoses are just descriptive. They are not explaining the symptoms, strictly speaking. If we say somebody's got a personality disorder, they don't have the symptoms because they've got the personality disorder. They have the personality disorder because they've got the symptoms. And I think complex PTSD is more of an explanatory diagnosis. It helps you to think about what's happened in this person's life, what's caused this, and it helps you make sense of a lot of what is going on in terms of symptoms, in terms of how that person's relating to the world and how they're relating to clinicians.
Thanks, John.
Here.
David Crossley, did you want to come back in? Or
Yes, just a little bit on that, because I think that the trouble with complex PTSD is it does rub up against, and I think in service design, you see it actually between clinicians who are more on the personality disorder end of the world, like Andy Williams perhaps, and the complex PTSD folk who are often found in psychology circles, I think, because there's a certain it's a more CBT oriented approach. But what it's I think that and I'm sort of equivocal between the two. But I think what complex PTSD doesn't do is give out any sort of constitutional account of the issues. And it doesn't also, and the other bit is that what happens if there's no trauma? And where is what does the phrase the bit about disordered self? I forget, Gordon will probably know this, but the bit about there's a disordered sense of self in the mix of a complex PTSD, which sounds precariously close to me to a personality disorder ascription. So I don't think we're out of the woods with complex PTSD, personally.
I think the issue of no trauma is a tricky one. I mean, I know one shouldn't digging for trauma or make assumptions that trauma is there, even if the patient's not admitting it to it. But you do get patients where I've had patients where I've known them for years and thought I knew everything there was to know about them, and then suddenly this, prompted by something, this history of early traumatization suddenly comes out and everything just suddenly looks much clearer. I think complex PTSD, I think, covers the spectrum. It does bring constitutional issues. If by constitutional you mean explaining things at a physiological level. I mean, people with complex PTSD often have dysregulated autonomic nervous systems. They cannot bring themselves back to some kind of equilibrium.
I suppose I was also thinking about the psychodynamic idea of a conflict, internal conflict, and that's a constitutional feature of personality. It's another sort of theory that can be brought to the discussion, really. And it's a theory of how people are, isn't it? Against the sort of idea about personality. So yes, biology and there are psychological theories which I think are more constitutionally framed, rather than just environmentally determined. And therein lies an issue, which is, well, where's the person? How do we understand people? We don't really, as psychiatrists, we don't really think about that very much. We end up narrowing our focus, and we are worried, I think, and with good reason, to try to be more holistic. And the more holistic we get, the more wobbly it might feel. Because there is a sort of instrumental attitude which we bring to our care, which is a good thing to do. And diagnoses help us to do that. They sort of help us to know what to do. But there is a loss involved in that you end up in a more specialized mindset, and you can lose the person. And that's part of the craft of the work, isn't it, I suppose?
Such complex work. I love this discussion, and I must go and listen to them properly. It's making me think of the Reef lectures that have just been delivered by Gwen Adshead. Okay, you know, she, albeit from a forensic psychiatrist, psychotherapist perspective, but some of that was in there, you know, why, you know, but particularly around violence, and, you know, can violence be related to mental illness, etc., which is interesting. But she kind of managed to walk the line, I think, of you know, understanding does not necessarily excuse, etc., when it comes to criminal acts. Can we come back to Rebecca? You've had inpatient psychiatric care in the NHS. I mean, I always worry, and maybe because you were a doctor, you would be treated differently. That our inpatient units can be quite toxic environments despite our best efforts. I mean, there's the old worry about a kind of us and them attitude from nursing staff and some more judgmental nursing staff. I think you were describing the you know, those who are genuine patients, you know, who are behavioral in inverted commas. I mean, did you see any of that going on around you? I think one of the passages you read, you touched on that a bit.
I think I was probably quite lucky, actually, and I do think there's a difference between, I mean, I've not been an inpatient for about 16 years or something, and you know, it was, I mean, it was awful, but it wasn't, you know, it could have been worse. I mean, it's difficult to know with the doctor, you know, being a, you know, I mean, I was a kind of pretty immature female doctor, you know, the kind of one that, you know, people could just have thought, what's she doing here? You know, and it's really hard to know, you know, you really just don't know what people thought at the time. And I didn't really know at the time. I just didn't really mix with people. I didn't find that really very easy. And then, but I remember recently, I have had outpatient ECT on a few occasions, which may or may not have prevented me being an inpatient, for which I'm extremely grateful. I mean, I see the wards now, and I just think, you know, I've said to my husband, do not let this happen, you know, just under no circumstances. And, you know, I mean, obviously that's an unfair thing to say to anyone, but on the other hand, I mean, their occupancy, you know, the whole thing they are very toxic now, with a lot of, I mean, you've got to feel sorry for the nurses. They're understaffed, and they're newly qualified nurses often who are in charge. And it's just, you know, I mean, I find myself hearing stories about it from trainees, from other people, much more than I used to. And it actually gets to me because of that, because of my previous experience, I think, which was obviously not what you want, but could have been worse. Whereas I think it would be absolutely awful now. And there's the issue, the big issue when you're a medic or a whatever, or particularly a psychiatrist working in the hospital, is, where are you admitted to? And there's the assumption that you'll go somewhere far away, but then none of your family can see you. The whole thing is just not ideal at all. So I think you are quite stuck with what you can do. I just hope it never happens to me again. But I think it is quite tricky, and you do hear. I mean, yes, of course, I've heard other staff talking about doctors and nurses, and it does get to you, even if it's nothing to do with you, but you can't help being affected by it. I just actually wanted to go back to the talk there about trauma and personality disorders and diagnoses, and really just to raise the Guardian review of my book, which have you read, Ian? The Guardian review.
David sent around, and I did read it. Yeah. I read it the weekend it came out. Yeah.
Yeah. Well, it was just such a not quite what anyone was expecting. I think it was basically saying that, it was all wrong and I needed immediate trauma therapy, which I think there wasn't quite the place to do that. And it was particularly, it was, who knows what trauma anyone's experienced. I mean, I know some of my childhood stuff probably wasn't ideal, but it wasn't that bad, and it was, I wouldn't have wanted my dad to read it. It was not the kind of thing I think you should write. But I was just interested when I had actually read it. But it was more a reflection of the writer's views on psychiatry, I think, rather than a review of my book. But
no, it was
anyway.
a bad review, I felt. Yeah, yeah, it wasn't a good review. I don't.
Yeah, think. From my perspective, it's nice to get a review in the Guardian. I'm not too worried about the content, but it was just I thought it was. It was someone who obviously felt strongly that none of this was the case, and it was all trauma without really any evidence at all, and they weren't, it was a bit odd.
What's the reviewer? Remind me, I've forgotten.
Horatio Clare.
Oh, yeah, no, I thought it was. He's had psychosis.
Yeah.
Yeah, and I've got a book by
possibly cannabis related. I've got a book by him too. I bought it the other day.
Yeah, I've got a book about being on the ocean in large container ships.
I think he's written some good things, but he's obviously decided to write about mental illness now, and I'm not too impressed by what I've read of his book, but I'm writing it from the perspective of being a traditional psychiatrist, so I still think it's good to read, and know more about.
I think he got you wrong. He got your book wrong, absolutely. Chris.
I was just wondering how typical he is, though, in reaction. I think it's a tremendous book. It's really well written and fantastic job, Rebecca. But is that review in The Guardian in any way, is it reflected in other people's responses, or is that?
No, not at all.
There's not a groundswell of kind of these ideas, very much anti.
No, no, I mean, not, I think there's one or two slightly things on Twitter, but you'd expect more actually on Twitter. Any feedback I've had about the review has been, what on earth was that? I think Professor Laurie is trying to take it further, but I did say I didn't want to have anything to do with that, but if he wants to, he can. Yeah, he felt that it wasn't accurate in its portrayal of psychiatry or something. Anyway, it's a bit difficult for me. I mean, I just, reviews and that is a review of my book. I think it's probably, it wasn't quite what I was expecting, but, Yeah,
reviews are tricky, aren't they? Because, you just need, well, I think your mindset will be like mine, Rebecca. Whenever I give a lecture to medical students, is the 1 in 100 complaint.
Yeah.
Yeah.
Doing that tomorrow morning. Yeah.
I'm very sensitive to that. Chris.
Thanks. Thanks very much, Rebecca. Really interesting. I'm glad you mentioned the review because I was livid. I thought it was graceful. Just I wasn't going to bring it up, but since you mentioned it yourself,
I thought I would. Yeah.
Incredibly ignorant, poorly written, massive assumptions. favorable to the book, but for the vast majority of it was a very ignorant and caricatured critique of psychiatry that didn't, so it's very, very frustrating to read that. So you must have been incredibly frustrated yourself.
He did seem to be trying to advertise his own book at the same time, which was, I suppose, quite clever.
And the real question was, I was just wondering, am I right in saying you were a patient before you were a practicing psychiatrist?
I was a doctor. I mean, I got through medical school, and I did part of my general practice training before I became ill, and I had wanted to do psychiatry, but I just thought, well, that's off the cards now. And so when I did finally manage to get back to work, I finished my GP training and then did psychiatry, which
I was just wondering if there has been experiences or insights on the patient side of things that you feel have influenced your practice as a psychiatrist. But I appreciate, obviously, there wasn't a before and after, if you like.
Yeah, it's kind of quite difficult to know. I mean, I think it does make you. I think there's often little things that make you think about things. Things that happen or you see. I think from. I mean, I think just generally you try and think more about what's happening on the other side. How does this feel to them? And being aware of the way people talk about patients is another one. Yeah, I mean, it was in the chronic pain MDT the other day. And I mean, I've been going there for ages. They're all very nice people, but someone was talking about someone whose situation was quite bad for them and using the word manipulate. And I just thought, I can't let that go. It's not appropriate. And actually, it was fine. Everyone agreed. But, I think it's, I think we do have to try and stand up for things when things are said that aren't right. I think we should be trying to say, and you do get fed up, and you get fed up working in slightly shady conditions sometimes, and that can get to you. But I think you just have to try. I think interestingly, one of this is quite a small bit of work that I did. I did GMC work for a while, seeing doctors, and not all of them were addictions. Most of them were, but some of them weren't. And anyway, it was, I think it was very interesting seeing them and thinking of, where they'd come from and what was going on for them, where they were going. And that was quite, because you tended to see them for a long period if you were their supervisor or whatever it was called. So it was interesting. And it was, I just felt that sometimes it was just an odd series of events that had got them to where they were. And it was, when I was unwell, I think I worried a lot about the GMC. So I think it was something that kind of struck a bit of a chord with me. But I think it was quite a good thing to do because it was just a very interesting thing, seeing these people who were being quite closely monitored, who were doctors as well and had the same sort of, not background as in sort of, where you come from, whatever, but were doing medicine and things and, what they were up against. And I think things have, I was thinking of the one of the things I've thought quite a lot about. I mean, I've got a daughter who's about to start as an FY2 in the summer. And, you kind of think, how's it changed? And it has changed a lot. And I don't think it's not like it's worse or better. It's just very different. I mean, when we did it, the hours were absolutely awful, but you were more part of a team because you were in one place more. I mean, I find psychiatric core training now, I just look at them and I think, all the crap for the portfolios and everything, you just think it's just all too much. People should be getting more of an experience. And it's become, I mean, it's, great people doing it, but they're having to tick box an awful lot of stuff. And we didn't really have to do that as much. And it's a bit of a, I had to kind of think of the sleep things because on-call wasn't good for me, but I'm not sure I actually did an A&E job in my youth and that was shifts. That was terrible. But, so, there's different things, but, I was thinking of actually when I got my jobs first, like getting a psychiatric job was quite tricky. Whereas I think now, I think it'd be particularly difficult for someone in my situation in quite the same way, because you just do it through a central thing. But on the other hand, one thing I've always felt was I got to work with the right people. So, you know, because I was more employed just directly. So I think that's kind of going off the point a little bit, but it's, you're just thinking of, you know, when I became a psychiatrist.
Yeah, I'm thinking of, I don't know if you've seen that book, Also Human, and I forget the psychologist's name.
Yes.
She helps doctors who become wounded healers, and I think there's a bit I did read in your books, I'm dipping into it, where you're confronted. So what does the digoxin do to your potassium up or down? You know, that's my main memory of being a medical student. You know, I'm turning up to learn things, and it's as if I'm being interrogated as if I should already know these things. You know, you know, should I have been reading the books that I couldn't really afford at that point?
I felt a lot of it was quite humiliating. I've had a few people actually who were at medical school with me comment on the first chapter in particular, just saying, "Gosh, yes, it was like that." You know.
There's a chapter in Also Human called Wednesday's Child, referring to the fact that junior doctors always rotate on a Wednesday and 4 months, 6 month placements.
Yeah.
And how traumatizing that whole immersive, you're suddenly front line, and maybe the supports aren't what they should be.
Black Wednesday,
Wednesday's Child,
That's a terrible day, that. But at least they get like about 5 days of induction now. We just got handed a bleep.
I remember that. And then somebody come in and diabetic
ketoacidosis. Well, it'd be good if we knew the word there.
Do we leave the ward round to treat this, or do we keep going? And the consultant is like an eyelid, you know, and treated the patient.
No, it's I look back with horror on some of that. I mean, I suppose there were one or two good times and funny moments, but it was pretty horrific. You know, didn't really enjoy it.
We're coming towards the end of our time.
I'm going to jump in if I may.
Oh yeah, Gordon, please. Yeah, absolutely.
Jump in, just and say thank you, and I think it underlines what a wonderful forum this is for colleagues just to talk about things in an open way. And Rebecca, that's been a wonderful contribution to this forum, and really appreciate that. It's such a great thing to do because it's so different from what you're, you know, implying psychiatry doesn't need, which is the wrong kind of certainty. And I talk about the importance of good certainty rather than knowing nothing at all, but it's got to be combined or held in tension with good uncertainty. And there's so much that's interesting, but the question of diagnosis is hugely important in so many different ways. And I think if people feel the wrong kind of certainty attached to a diagnosis, that can be very, very unhelpful. And, you know, your question about what attitude should I bring to a patient who's had lots of diagnoses, I think bringing an attitude of appropriate uncertainty relating to being phenomenological rather than getting too hung up on what can be looked at in a fix. I think that itself is really helpful. I mean, complex PTSD was mentioned, and with dissociation, and I find it fascinating in terms of the sociology of belief system. That when I started as a consultant, I started to become interested in the phenomenology of dissociation, which I only learned about when I did psychotherapy at the end of the clinic with psychiatric patients. I didn't know before then, even though I was doing EMDR and interest in trauma. When I started to talk about that with colleagues, that elicited vicious reactions and DIDs made up and so on. I thought it was when I started, but now all the prevalence figures suggest it's more common than schizophrenia. And it took me 5 years of doing that phenomenological work with my psychiatric patients in depth to realize that it wasn't ridiculous. So that DID has a high prevalence. So that was just one, you know, instance of that. So being very open and listening to people can be very different from having Procrustean ideas. You know, and if one goes further than that and one asks them the right kind of questions, they can be brought to tears because you understand something of what's going on that they've always been because it's been too shameful. So that, I mean, that's just one thing that was brought up when I was listening to, you know, so many stimulating points that you were bringing up, as well as questions of responsibility. And I love the word, bringing in the word absolution. That relates to deserving and shame and responsibility. Huge existential questions. And actually, my last patient today, I was saying, we've got to ask big questions here is, in terms of responsibility, a lot of it's what happened to you, but are we really responsible for the fact that we exist at all? So we've got to be responsible in the present, but can we hold ourselves responsible in the past for being inadequate people or behaving badly? Well, yes, we have to in the present, but were we responsible then for being less conscious or whatever? So I think we have to have a psychiatry where we can ask big questions like that as well. I'm rambling, but just saying thank you and lots of stimulating connections and thoughts that you've elicited in me anyway. So thank you.
Was that Sartre, Gordon? I think Condemned to be Free.
Well, I think the existentialists get everything wrong in terms of living in a meaningless universe, but they write wonderfully about freedom. I would say that. Unusually for me.
It is Sartre. Maybe Camus? No, Sartre, I think. Peter Benny had to leave, but he thanked you for your insightful talk.